Good afternoon, everyone. Myself, Dr. Sagar Makhija, Assistant Professor in Index Medical College. So, my today's topic is about acne vulgaris. It's the most common skin condition seen in adolescent age group. So, let's start this topic. Introduction. Acne is a chronic inflammatory disease of the pilosebaceous unit. It is characterized by seborrhea, that is oily skin, formation of open and closed comedones, erythematous papules and pustules, and in more severe cases, nodules, deep pustules, and pseudocysts. This is the definition of acne. Although acne is described in very ancient writings dating back to Iber Papyrus, it is clear description is found after Fish coined the term acne vulgaris, and Erasmus Wilson separated it from acne rosacea. From ancient Greece comes the English word acne, meaning point or peak. The earliest description of acne appeared in ancient Greek writings of the Byzantine physician Aetius Embedinus. So we'll start with the epidemiology. Race. All races worldwide are affected. However, Japanese population is affected less than the Americans. Age. A peak in the prevalence and severity occurs between 14 and 17 years in females, when 40% are affected, and 16 to 19 years in males, or 35% are affected. Smokers have a severe grade compared to a non-smokers. Genetic. Children with acne have one or both parents with acne in many cases. Similarities found in monozygotic twins. A correlation between neonatal acne and familial hyperandrogenism has been suggested. The association of very severe acne with XYY syndrome has been recorded. In those patients with very mild disease, the problem is referred to as physiological acne. Acne develops earlier in females than in males, which may reflect the earlier onset of puberty. Site of involvement is linked to the age of onset of disease, with inflammatory lesions in the midline of the face presenting early in sexual maturation. By 20 to 25 years, the tendency for acne to resolve is slowly. Also, in age group of about 30 years, acne lesions are mainly seen in the mandibular area. So the next topic is etiopathogenesis of acne. How is acne formed? So the four major factors involved in the etiology of acne are seborrhea, comedone formation or comedogenesis, colonization of the intrafollicular duct with petrous acne, and inflammation. So these four main factors are involved in the pathogenesis of acne. So the first is seborrhea. Excess sebum production is a prerequisite for the development of acne. As acne is a disorder of pilosebaceous unit, so excess sebum is a main cause for acne. Mechanism. What are the causes for excess sebum secretion? First is excessive androgen secretion or hormones. Androgens regulate the sebaceous gland function through binding through nuclear androgen receptors. In acne patients, there is marked heterogeneity in individual follicular sebum secretion. Certain follicles may be prone to acne, and that an enhanced peripheral or end organ response to androgens is a probable factor in many patients. So the increased androgens uh, can cause excess sebum production. Sebaceous gland in acne-prone regions show abnormally high 5-alpha reductase activity in vitro. The second factor is quality of sebum. There is also evidence to suggest that sebaceous gland can synthesize free fatty acids with high levels of squalene and fat wax esters found in the acne patients. Lipids may be involved in ductal hypercornification or may be essential to the growth of bacteria. So, in this sebum, high levels of squalene and fatty esters are responsible for acne. Third is increased availability of free androgens, which may be associated with relative reduction of sex hormone binding globulin or SHBG. An amplified target response mediated through the conversion of testosterone to more active dihydrotestosterone by the enzyme 5-alpha reductase. An increased capacity of the intracellular receptor to bind to the androgens. Now, the next important factor for pathogenesis of acne is comedogenesis. An important feature in the etiology of acne is the presence of ductal hypercornification, which can be seen histologically as microcomedones and clinically as blackheads, whiteheads, and other form of comedones such as macrocomedones. So, comedones is the pathogenic lesion or the skin feature of acne. Increased production of keratinocytes evidenced by increased K6, K16 and increased adhesion due to persistence of desmosomes lead to retention hyperkeratosis. Several factors have been implicated in the induction of keratinocyte hyperproliferation, which include sebaceous lipid composition, decreased linolenic acid and increased free fatty acid and squalene, androgens, local cytokine production of interleukin 1 and decreased VGF, and bacteria. So this will all cause increased proliferation of keratinocytes. Now this is the chart which shows the various pathogenic features responsible for acne. Oxidized squalene will increase interleukin 1. P acne will also increase interleukin 1, which will cause keratinocyte activation and hyperproliferation, resulting in hyperkeratinization. And this all will get stimulated with androgens. Now, the third pathogenic feature is colonization by P. acnes. The major organism isolated from the surface of the skin and the pilosebaceous duct of patients with acne are P. acne, P. granulosum, Staphylococcus epididymis, Malassezia furfur. The cornified plug within the pilosebaceous duct obstructs the sebum outflow, allowing Propionibacterium acne to multiply, but preventing them and their products of metabolism from escaping onto the skin surface. So the main organism responsible for acne is Propionibacterium acne. Now it is also known as Cutibacterium acne. There is damage to the basement membrane, permitting leakage of the comedonal contents into the dermis, thereby triggering the adaptive immune response to ductal antigens. Also, stress-related proteins may increase as a result of trapped bacteria, such as heat shock proteins, and DTS response may be an autoantigen or persistent microbial pathogen. Now, because of this, there is activation of toll-like receptors either by the pathogen-associated molecular patterns or endogenous ligands. Propionibacterium acne cell wall or a component acts as a PAMP and activate toll-like receptor 2 and 4 on keratinocytes, thereby inducing nuclear factor Kb and switching on to the production of pro-inflammatory cytokine interleukin 1 alpha. These bacteria produces increased lipases responsible for the hydrolysis of triglycerides to free fatty acids. They also produce protease, lecithinase, hyaluronate lyase, which are pro-inflammatory. Now, P-acne will secrete lipase enzyme, which will degrade the triglycerides into free fatty acids. This will result in increased antimicrobial peptides, resulting in inflammation and follicular cell or wall rupture. Apart from this, it also activates toll-like receptor 2 and 4 on the keratinocytes. And the newer pathogenesis mechanism is increase in matrix metalloproteinase, MMPs. Now, the fourth pathogenic factor is inflammation. Inflammation in acne occurs prior to the hyperproliferation of follicular wall, and that inflammation is dominated by CD4 T helper cell and a macrophage infiltrate. Factors favoring inflammation. Decreased linoleic acid leads to defective barrier function within the follicular infundibulum and increased presentation of T acne to Langerhans cells. This would lead to a greater opportunity for Propionibacterium acne and viable keratinocytes to interact with the follicular wall, leading to a release of pro-inflammatory cytokines, the interleukin 1 alpha, TNF gamma. Synthesis of leukotriene B4 is catalyzed by 5-lipoxygenase and increased by inflammatory mediators including complement fragments, TNF alpha, and interleukins. In addition, TL toll-like receptor 2 activation by Propionibacterium acne also plays a role. In patients prone to scarring, there is chronic delayed type of hypersensitivity reaction provoked by a persistent antigen which these patients are initially unable to eliminate. So apart from this, other pathogenic mechanisms are follicular interleukin 1 alpha stimulates surrounding vascular endothelial cells to elaborate further inflammatory markers like P-selectin, vascular cell adhesion molecule 1, and human leukocyte antigen. Toll-like receptor-mediated cytokine also induce matrix metalloproteinase that plays a role in acne inflammation, dermal matrix destruction, and scar formation. PPAR partly regulates sebum production. Insulin, like growth factor 1, can induce steroid response binding protein which stimulates sebaceous gland lipogenesis. Now, apart from this pathogenesis, there are various physiological and environmental factors that influence acne. First one is diet. Dietary factors, particularly the sweets, chocolates, fats, are frequently regarded by the patients and physician as the cause or aggravator of acne. Such things are really consumed in high quantity by adolescents. So this will all aggravate the acne. Diet with high glycemic index can lead to hyperinsulinemia and result in a cascade of endocrine triggers, including increased insulin-like growth factor, altered retinoid signaling, and increased androgen, thereby mediating acne pathogenesis. So we need to avoid high glycemic index foods. Other factors are premenstrual flare. Flaring is related to a premenstrual change in the hydration of pilosebaceous epithelium. Up to 15% of the acne patients notice that sweating causes a deterioration in their acne, especially if they live or work in a hot, humid environment. So working in a hot, humid environment can aggravate acne. UV radiation may enhance the comatogenicity of sebum occupation. Hydration of the ductal stratum corneum may induce acne in such occupations as scattering and steam cleaning. Patients dealing with oil may develop an acneiform oil folliculitis, particularly on the trunks and lips. The most important factor recently noticed is stress. Corticotropin releasing hormone induces the synthesis of sebaceous lipids in vitro, and adrenocorticotropic hormones, melanocortin, evokes adrenal dehydroepinestrone to regulate skin inflammation. These current findings indicate that central or topical stress may indeed influence the feedback regulation, thus inducing development of clinical inflammation in early acne. Now, in this, there are various sequence of events in the development of acne. The first one is sebaceous cells or sebum secretion, mainly free fatty acids. Second is comedone formation, closed comedones, open comedones because of sebum accumulation, follicle enlargement, and keratinous material piled up, leads to microcomedone formation. And with the help of propionibacterium acne immune reactions, they're responsible for inflammatory lesions. And the last is follicular keratinocyte hyperproliferation, resulting in microcomedone formation. Now, the next topic is clinical features of acne. After etiopathogenesis, what are the clinical features of acne? Now, what is the most common site for acne is the face, 99%. Back can be involved in 60% of patients, and chest in upper 15% of patients. Other areas like shoulders, upper arms, and scalp can be involved in severe cystic form of acne. What cutaneous lesions of acne? First is the comedones, known as it is formed due to a plug of keratinins and sebaceous material locked in a pilosebaceous unit. The pathognomic feature of acne. What are the types of comedones? Open comedones represent dome-shaped papules in which there are dilated follicular outlets filled with keratin. The apparent black color is thought to be due to melanin deposited within the cellular debris. So open comedones are also known as blackheads. Next is closed comedones or whiteheads. They are generally 1 millimeter in diameter, skin color, and have no visible follicular opening. Third is sandpaper comedones consist of multiple very small whiteheads frequently distributed on the forehead, which produces a rough, gritty feel to the skin. Fourth is macrocomedones are large whiteheads or occasionally blackheads more than 1 millimeter in diameter. Submarine comedones are large comedonal structures greater than 0.5 centimeter in diameter and are resident more deeply in the skin. They are frequently the source of recurrent inflammatory nodular lesions. Secondary comedones may be produced after exposure to dioxins, like known as chloracne, pomades used for various hair gels, pomade acne, topical steroids, and other drugs causing drug-induced acne. Inflammatory lesions arise from the microcomedo or non-inflammatory lesion and can develop into superficial or deep lesions. Now, the superficial inflammatory lesions are the papules and the pustules, which are 5 millimeter or less in diameter, and deep lesions can cause deep pustules and nodules. Sinus formation between the nodules and deep pustules leads to devastating cosmetic effects and inevitable scarring. They are frequently very tender, chronic, and resistant to the treatment. Itching is a rare but may relate to the release of histamine-like compounds from propionibacterium acne. So the severe form of acne will result in nodular cystic acne. what are the scoring systems used for acne? In 1956, Pillsbury, Shelley, and Kligman published the earliest grading system, which includes grade 1 is comedones and occasionally small cysts confined to the face. Grade 2 acne is comedones, occasionally pustules and small cysts. Grade 3 is many comedones and small and large inflammatory papules and pustules, more extensive but confined to the face. And grade 4 is many comedones and deep lesions, tending to coalesce and canalize and all the face and upper aspect of the trunk. So, in 1997, Doshi, Zahir, and Stiller devised a global acne grading system which divides the face, chest, and the back into 6 areas, that is, forehead, face, cheeks, nose, chin, chest, and the back, and assigns a factor to each area on the basis of size. So, for forehead, the factor was 2, right cheek, left cheek, 2, nose 1, chin 1, and chest and upper back 3. Score of 1 to 18 is considered mild, 19 to 30 is moderate, 31 to 38 severe, and more than 39 is very severe. Now, the clinical grading which we use in our OPD is this. That is, acne vulgaris was graded by Indian authors using a simple grading system which classifies acne into 4 groups. Grade 1 acne is comedones with occasionally papules. Grade 2 acne is papules, comedones, and few pustules. Grade 3 acne is predominantly pustules, nodules, and abscess. And grade 4 acne is mainly cyst, that is nodular cystic acne, abscess, and widespread scarring. Now, after considering the pathogenesis, clinical features, and bleeding of acne, the next topic is complications. What are the complications of acne? Persistent post-inflammatory hyperpigmentation is seen most frequently in pigmented skin and post-inflammatory erythema. So it is also known as PIH or post-inflammatory hyperpigmentation. So it is very important not to pick up the acne as it will result in these complications. Second complication is pyogenic granulomas, which develop very infrequently in patients with very severe disease of the trunk or following oral isotretinoin. It's a side effect. Third is scarring, usually follows deep-seated inflammatory lesions, but can also occur as a result of more superficial inflamed lesions in the scar-prone patients. And fourth is depression, suicidal ideation, anxiety, psychosomatic symptoms, or body dysmorphism. Being a cosmetic condition, many patients are prone to develop this. And among these complications, scarring is the most common complication. Now, what are the types of scars? There are two types of scars seen in acne patients. First is hypertrophic scar, and second is atrophic scars. So, hypertrophic scars means the scars which are enlarged. They do not extend beyond the extent of original inflammation. And the second scar is the atrophic scars. Now, what are the types of atrophic acne scars? First is atrophic macular scars. They are frequently multiple and represent soft, distensible lesions. They often retain a vascular hue for many months before becoming white and less conspicuous. So, first one is the macular scars. The second is ice pick scar. They are narrow, less than 2 millimeter deep, sharply marginated epithelial tracts that extend vertically to the deep dermis or subcutaneous tissues. So this is one of the most common scars, that is ice pick scars. Third type is box scar scars. They are round to oval depressions with sharply demarcated vertical edges, similar to the varicella scars or chickenpox scars. They are clinically wider at the surface than ice pick scars and not taper to a point at the base. The next type is rolling scars. They arise when the fibrous band of the tissue develops between the skin and the subcutaneous tissue. These bands hold the epidermis, binding it to the deeper structures of the skin. This type of scarring causes rolling or wave-like undulation across otherwise normal. These four are the types of atrophic scars: macular scars, ice pick scars, box scars, and rolling scars. Now, the next complication which can occur is perifollicular elastolysis. PFE is commonly found on the trunk and consists of multiple follicular atrophic looking lesions, sometimes seen without the evidence of acne. The rarest complication of scarring can result in calcification or calcium deposition. Now, the European Acne Academic Group has renamed the atrophic acne scars as V-shaped or ice-pick scars, U-shaped or box scars, and W-shaped or rolling scars. Goodman and Baron proposed a qualitative scale and then presented a quantitative scale for acne scars. Reno introduced the PCA scale for acne scars. So this is the Goodman and Baron qualitative grading for acne scars. This includes grade 1, 2, 3, 4, that is macular, mild, moderate, and severe. So in first we would have just flat hyper or hypopigmented flat marks. Second is mild atrophy or hypertrophy, which may not be obvious at a social distance of 50 centimeters. Third is moderate, that is moderate atrophic scarring, which is obvious at a social distance of 50 centimeters and is not covered easily by a makeup. Severe. Severe atrophic or hypertrophic scarring that is evident at a social distance more than 50 centimeters and is not covered easily by a makeup and is not able to be flattened by manual stretching also. Now the next topic is what are the syndromes which are associated with acne. Now the most common syndrome associated is PCOS or PCOD, also known as polycystic ovarian syndrome. It consists of irregular menses, obesity, androgenetic alopecia, hirsutism, and acne. So in such patients, we will find a constellation of signs and symptoms of irregular menses, obesity, alopecia, and acne. Second syndrome is Heron syndrome, also known as hyperandrogenism in acne, insulin resistance, and acanthosis nigricans. Third is Papa syndrome, known as pyogenic arthritis, pyoderma gangrenosum. Next is Sappho syndrome, known as synovitis, acne, pustulosis, hyperostosis, and osteitis. Next is Saha syndrome, which is also seen in PCOS patients, known as seborrhea, acne, hirsutism, and alopecia. Next is Apert syndrome, symmetrical syndactyl acneiform eruption, abnormal sensitivity to circulating androgens. Now the second last topic is what are the investigations you would do in patients of acne. The laboratory workup is not indicated with acne unless hyperandrogenism is suspected. In such patients, we have to suspect whether you will find hirsutism or signs of PCOD. So elevated serum levels of androgen has been found in cases of severe cystic acne and cases of endocrine abnormalities like congenital adrenal hyperplasia, adrenal tumors, or PCOS. So what are the reasons for investigation? In which patients we need to do the investigation? When a patient comes with severe or sudden acne, or in severe or sudden acne, in therapy resistant acne, rapid significant relapse post isotretinoin, additional signs of hyperandrogenism, irregular menses, hirsutism, and hypersaturia, unusual clinical presentation, multiple comedones, and mature onset or perioral distribution. Now, what test we will do in such patients? We have to go for androgen profile. It consists of total testosterone and free testosterone levels. Next is sex hormone binding globulin, 17-hydroxyprogesterone, LH, FS, FSH, or estradiol. Next is we have to test is serum prolactin levels and thyroid function test. Also, other tests which include our assessment of glucose intolerance or insulin resistance, that is glucose tolerance test, fasting and postprandial blood insulin levels, lipid profile, suspected Cushing syndrome, dexamethasone suppression test, and ultrasonography of pelvis, mainly done on the second day of menses. Now, what are the differential diagnoses of acne? First is rosacea. Second is drug-induced acne. Lupus, filariasis, disseminata fleshi, LMDF. Psychosis, Barbie. Gram-negative folliculitis, Demonix folliculitis, and trichostasis spinosa. Now, what are the other variants of acne? First is neonatal and infantile acne, seen in infants less than 3 months of age due to elevated plasma androgen of maternal origin. Senile acne seen in more than 50 years of age. Comedones are localized to the temple and forehead. Excess oil can cause the acne. Third is chloracne due to aromatic chlorinated hydrocarbons. Ingestion of tetrachlorobiphenyl as contamination of edible oils can cause epidemic acne. Chemical acne due to contact with heavy oils, wax, cutting oils, and coal tar derivatives. Mechanical acne because of pressure and friction causing acneiform eruptions. Neck of violin players, fielders acne, underarm bands and straps. Tropical acne is people working in hot and humid climate, mainly over the back, upper arm, buttocks, and thighs. Acne excori commonly seen in females who scratches the lesion associated with mental stress or personality disorder. Acne conglobata or chronic highly inflammatory disease found in men with excess Y chromosome or Klinefelter syndrome. Elevated LH and FSH levels are found, and it is characterized by comedones, papules, pustules, nodules, cysts, burrowing intercommunicating abscesses with mutilating scars. Now, what is acne fulminans? It is an ulcerative form with acute onset and systemic symptoms. Osteolysis or destructive osteomyelitis may occur, may be associated with pyoderma gangrenosum-like lesions and posterior scleritis. Pomade acne occurs when some of the pomade that is applied to the scar is also applied to the forehead and responsible for the development of multiple closely packed pomadoms close to the hairline. Pyoderma faciale is sudden fulminating onset of pyoderma, that is skin infection in a young, usually in the early 20s. Mild acne which erupts with inflammatory nodulocystic lesions of the face. Next is acne estivalis or Mallorca acne. Females starts in the spring and resolves with autumn. Small papules on the cheek, neck, and upper body. Acne tarda is adult onset acne more than 35 years of age. Morbihan's disease is the disfiguring complication of acne with woody non-scaly induration with erythema over the midline of the face and cheeks. The last is acne cosmetica, refers to the acne caused by or aggravated by cosmetics. The mechanism presumably is a chemical induced plugging of the pilosebaceous orifice, example benzoic acid or butyrylsterol. Different non-comedogenic makeups are preferred in such patients. Now, the last part of disease is the treatment. What are the general measures? Education and counseling regarding the nature, course of the disease, and treatment modalities. To avoid the use of oils, pomades, and heavy cosmetics. To eliminate emotional stress and to educate regarding the premenstrual flare. Such measures should be observed by the patient. Now, what is a topical therapy used in acne? Now, there are various options available for topical management of acne. First one is topical retinoids. Topical retinoids, they bind to the retinoic acid receptors and affect the gene expression. It reduces the number of microcomedones, mature comedones, promote desquamation of follicular epithelium and anti-inflammatory action. The various topical retinoids available are topical tretinoin, isotretinoin, adapalene, and tazarotene. So topical tretinoin is available in the concentration of 0.025%, 0.05, 0.01, and 0.1. Isotretinoin adapalene 0.3 and 0.1% gel. Other topical agent used is topical benzyl peroxide. It is an antimicrobial, anti-inflammatory, and anti-comedogenic effect. It is available in the concentration of 2.5, 5, and 10%. So it acts by oxidizing. It acts by oxidization. Now the third topical antibiotic is topical clindamycin 1%, 2% erythromycin, 1% nadifloxacin, 5% dapsone, and 10% sodium sulfacetamide. A combination of topical retinoids or VPO with erythromycin or clindamycin is very effective. Other topical agents used are salicylic acid 2% gel or as a cleanser, sulfur 1 to 10%, azelaic acid 10 to 20%, and picolinic acid 10%. So salicylic acid will act like it's in mild form, it's keratolytic, and it is mainly used in oily acne. Now, what are the oral treatment used for acne? So the first line of treatment includes tetracycline group of drugs. Oral tetracycline 500 mg BD, doxycycline 50 to 100 mg BD, Minocycline 150 to 300 milligram OD and minocycline 50 to 100 milligram BD. Alternative drugs used for systemic therapy includes oral erythromycin 500 milligram BD or Septran DS, that is 800 to 160 BD. Now the main drug which is used in acne are oral retinoids. These are the drug of choice in severe acne, that is grade 3 and grade 4 acne, that is severe nodular cystic acne. It's an FDA approved drug. Other indications include gram-negative folliculitis, acne fulminans, and pyoderma facial. And also, it is also used when there is failure of conventional therapy, acne with psychological distress, inflammatory acne with scarring, and the approved dose is 0.5 to 2 milligram per kg per day over a 20-week course. This for 5 months. Till the CD of 120, that is cumulative dose of 120 to 150 milligram per kg is attained. Now, in patients where you will find elevated levels of androgens, patients should be started on hormonal therapy. It is indicated in hyperandrogenism, acne tarda, that is adult onset acne more than 35 years, persistent acne, and perimenstrual flare. Ethinyl estradiol 100 microgram or in combination with progesterone, commonly seen as oral contraceptive pills, tablet dian 35. Second is anti-androgens. Spironolactone 50 to 100 milligram daily or flutamide 50 milligram daily, cyproterone acetate CPA can be used. Glucocorticoids, prednisolone 2.5 to 5 mg with oral contraceptive pills and acne fulminants and pyoderma facially. Now, apart from the oral treatment, what are the physical modalities of which we can use in acne? First is comedone extraction. This is the simplest procedure which is mainly indicated in deep, incipient and persistent comedones, which helps in the removal of comedones. Second is chemical peeling, which is indeed helpful in acne patients. And various chemical agents used are 10 to 70% glycolic acid, Jesner's solution, and 10 to 30% salicylic acid. It helps in faster resolution of acne. Third is intralesional steroids. It is mainly used for nodulocystic acne lesions, usually written triamcinolone acetonide. Fourth is phototherapy. Trials have reported treatment with 415 to 430 nanometer, 600 nanometer, and 430 to 1100 nanometer to be safe in mild to moderate acne, as it causes suppression of original acne. Fourth is cryotherapy, and fifth is laser. In laser, there is high intensity narrow band blue light, green light lasers at 500 nanometer, yellow, PDL or IPL laser. Photodynamic therapy, that is PDT, with aminolevulinic acid can be used in moderate to severe acne, and radiation therapy, superficial access can be beneficial. Now, apart from this, if patient has multiple acne scars, which we have seen previously, so what are the surgeries which we can use in patients of acne scars? First is punch excision. Second is elliptical excision for scars more than 3.5 millimeter in diameter. Skin grafting in case of sinus formation. Punch elevation and depress box scars. Subcision, it is mainly used for rolling scars. Microdermabrasion MDA for superficial acne scars. Percutaneous collagen induction by microneedling or derma roller or derma pen. This is the most preferred technique used, or tissue augmentation in the form of dermal fillers or fat transfer. Apart from this, there can be various lasers which can be used for acne scars and which are highly effective, which includes ablative carbon dioxide laser for shallow box scars or herb nutrient laser, non-ablative laser for rolling or hypertrophic scars. The fractional CO2 laser is the most commonly used laser. Newer treatment modalities are zilutin, that is lipooxygenase inhibitor, ectopeptidase inhibitors, thiazolate and pyrrolate, that is actinonium, suppress zigocyte proliferation, topical dapsone, propionate acne vaccines targeting surface celidase, and PAL 19403 monomolecular antibiotic. So, these are the references for today's topic. So, today's topic is of acne. Thank you so much.